There is a story that gets told in emergency rooms across America every single day. A woman walks in. She is in pain. Real, documented, measurable pain. She describes it. She waits. And then, more often than not, something happens that has been happening to women in medical settings for over 2,000 years. She is not believed. A 2024 study published in the Proceedings of the National Academy of Sciences analyzed over 21,000 emergency room visits across the United States and Israel. The findings were unambiguous. Women waited an average of 30 minutes longer than men to receive care for the same symptoms. They were less likely to receive pain medication. They were more likely to be told their pain was psychological. They were more likely to be sent home without a diagnosis. That study was published in 2024, not 1924, not 1824, only 2 years ago. And here is what makes that number genuinely shocking. The gap between how medicine treats women's pain and how it treats men's pain has not narrowed meaningfully in the last century. It has been there for so long and gone so unquestioned for so long that most women have simply accepted it as part of the experience of having a body. Today we are going to find out why, because this did not happen by accident. It was built, deliberately, over millennia, by the most respected scientific and medical minds of every era. And the story of how it was built and who it has killed is one of the most important stories nobody ever told you. Stay with us, because what you are about to hear will make you look at every medical appointment you have ever had in a completely different way. Ancient Greece, the wandering uterus. To understand where we are, we have to go back to where it started. Ancient Greece, roughly 400 years before the Common Era, the most advanced medical civilization in the Western world. Hippocrates, the man whose name is still attached to the oath every doctor takes, was writing what would become the foundation of Western medicine for the next 2,000 years. And here is what he wrote about women. He believed the uterus was a living organ, an organ with its own desires, its own needs, its own ability to move independently through the body. When a woman experienced pain in her abdomen, her chest, her head, anywhere, Hippocrates had an explanation. The uterus had wandered from its proper position and was pressing against other organs, causing disruption. The cure was to lure it back. Strong smells placed near the nose to drive the uterus downward. Pleasant smells placed near the vagina to attract it back to its rightful location. Marriage and pregnancy were prescribed as long-term treatments on the theory that a uterus occupied with its proper function would not wander. This was not a fringe theory. This was mainstream medicine, taught in the most prestigious medical schools, practiced by the most respected physicians. Plato wrote about it. Aretius of Cappadocia described the uterus as an animal within an animal, capable of moving upward toward the liver and causing suffocation. They named the condition after the Greek word for uterus. They called it hysteria. And that single word, and everything it encoded about women's bodies and women's pain, would shape Western medicine for the next 24 centuries. Rome to the Middle Ages, pain as moral failing. Rome inherited Greek medicine and expanded it. Galen, the most influential physician of the Roman Empire, elaborated on the theory of the wandering womb and added his own contribution. He believed that women who did not have regular sexual intercourse accumulated a toxic substance in the uterus that poisoned the blood and caused the symptoms of hysteria. Widows and virgins, he noted, were particularly susceptible. The prescription was the same as it had been in Greece. Marriage, pregnancy, sexual activity. The body of a woman in Roman medical thinking was fundamentally incomplete without a man. Her pain was not a medical problem to be solved. It was a biological condition to be managed through the proper social arrangements. When the Roman Empire fell and the medieval church consolidated power over medical practice across Europe, the wandering womb gave way to something darker. The church taught that suffering was spiritually meaningful. Pain, particularly women's pain in childbirth, was explicitly described in Genesis as divine punishment for Eve's sin. To seek relief from pain was, in some interpretations, to resist God's will. Women who suffered from unexplained pain, seizures, episodes of unconsciousness, or extreme emotional distress were increasingly viewed through a theological lens. The same symptoms that Greek physicians had attributed to a wandering uterus were now attributed to demonic possession or witchcraft. The treatment moved from medicine to the church, and in extreme cases to execution. The women who might have been patients became suspects. The pain that might have been treated became evidence of sin. The history of women's pain in the medieval period is largely a history of what happened when the wrong framework was applied to real suffering. The 17th and 18th centuries. Hysteria gets a diagnosis by the 17th century. The Church's grip on medicine was loosening. A new generation of physicians was looking for scientific explanations, and they turned back to hysteria, but now they gave it a more sophisticated framework. Thomas Sydenham, one of the most celebrated physicians in 17th century England, declared that hysteria was the most common disease of his time. He estimated that fully half of all chronic diseases were hysterical in origin. He described it as a condition that could produce almost any symptom: pain, paralysis, blindness, seizures, fatigue, emotional disturbance, and that primarily afflicted women. The cause, he believed, was weakness of the nervous system combined with the inherent emotional instability of the female constitution. Notice what had changed and what had not. The wandering uterus had been replaced by a nervous system. The language was more scientific, but the underlying assumption was identical. Women's bodies were fundamentally different from men's bodies in ways that made them prone to irrational, exaggerated, untrustworthy experiences of pain and illness. The word hysteria had evolved. The belief it encoded had not moved an inch. Through the 18th century, hysteria became fashionable, almost. Wealthy women were diagnosed with it constantly. It was considered almost a mark of refinement, a sign of a sensitive and delicate constitution. Working-class women, by contrast, were assumed to be too robust for such ailments. Their pain was attributed to laziness or weakness of character. The class dimension of women's pain dismissal runs through the entire history of this subject. Not all women's pain was dismissed equally. The 19th century, the treatments that damaged women. The 19th century brought what appeared to be a more serious engagement with women's pain. Hysteria was studied, documented, classified. The great neurologist Jean-Martin Charcot at the Salpêtrière Hospital in Paris put hysterical patients, almost all women, on public display for medical audiences and paying visitors. He photographed them, he induced their symptoms with hypnosis. He built a career on the spectacle of women in distress. Sigmund Freud, who trained under Charcot, took the theory indoors and turned it into psychoanalysis. Hysteria, he argued, was caused by repressed sexual trauma or desire. The symptoms were real, but their origin was psychological. The treatment was talking, specifically talking to Freud or one of his followers, often for years. Meanwhile, gynecologists were doing something far more damaging. J. Marion Sims is still celebrated in some medical histories as the father of modern gynecology. He developed surgical techniques that genuinely advanced the field. He also developed them by performing repeated surgeries without anesthesia on enslaved black women in Alabama, operating on some patients as many as 30 times. His reasoning, shared by many of his contemporaries, was explicit. He believed black women had a higher pain tolerance than white women, that their nervous systems were different, that they felt less. This belief, that black women's pain was less real, less urgent, less worthy of treatment, was not eliminated when slavery ended. A 2016 study found that half of white medical students and residents still held false beliefs about biological differences in black patients' pain tolerance. That study was conducted in 2016 in medical schools. The 19th century also gave women opiates, chloral hydrate, and a treatment called the rest cure, developed by physician Silas Weir Mitchell, which confined women to bed for weeks or months, prohibited them from reading, writing, or socializing, and prescribed force feeding. Charlotte Perkins Gilman, who underwent the rest cure, wrote a story about it afterward. She called it the yellow wallpaper. It is about a woman who goes mad. The 20th century, when women were excluded from the research here, is a fact that sounds impossible but is completely true. Until 1993, women were routinely excluded from clinical drug trials in the United States. The official justification was that hormonal fluctuations complicated the data. The practical result was that the majority of drugs developed, tested, and approved throughout the 20th century were tested almost exclusively on male bodies. Dosages were calculated for men. Side effect profiles were built from men's responses. The standard human body in medical research, the default patient, was male. This meant that when women took these drugs, they were taking medications that had never been tested on their physiology. When they experienced different side effects, or needed different doses, or had different responses, there was no data to explain it. There was only the assumption that something was wrong with the woman. Aspirin was tested for cardiovascular protection primarily in men. The early AIDS research almost entirely excluded women, despite women dying from the disease, because researchers did not want to deal with the complications of studying pregnant women or women of childbearing age. Heart attack symptoms in women present differently from men, but the textbook descriptions of heart attack symptoms were built from male data. Women were misdiagnosed and sent home from emergency rooms with antacids while they were having heart attacks. The exclusion of women from research was not malicious in most cases. It was simply the consequence of 2,000 years of treating the male body as the medical default and the female body as a complicated variation. Today, the gap that remains in 2024, a woman with endometriosis waited an average of 7 to 10 years to receive a diagnosis, a condition affecting 1 in 10 women of reproductive age, causing chronic, debilitating pain, took nearly a decade to be correctly identified. During those years, she was told her pain was normal, that it was part of being a woman, that she was being overly sensitive. 62% of women reported in 2024 that their pain had been dismissed by healthcare professionals. That number had increased by 27% from the previous year. 1 in 3 women felt dismissed and unheard in medical settings. The most common experience reported was being told that their pain was psychological, that it was related to stress, or that it was simply part of being female. These numbers are not historical artifacts. They are current, they are now, and they connect in a direct, unbroken line to Hippocrates writing about the wandering uterus in 400 BCE, to Galen attributing women's pain to sexual deprivation, to Thomas Sydenham diagnosing half of all illness as hysteria, to J. Marion Sims operating on enslaved women without anesthesia, to the medical establishment excluding women from clinical trials until 1993. The gap is not a glitch in an otherwise functional system. It is the system operating as it was designed to operate, with the male body as the norm and the female body as the deviation. What changed and what hasn't progressed is real. Women are now included in clinical trials. Endometriosis has a growing research community. The gender pain gap is being studied, named, and publicly debated in ways it never was before. The 2024 Lancet paper calling for recognition of gendered pain was published. Australia launched its first national inquiry into women's pain. The CDC updated its guidelines for IUD insertion after women posted about their pain experiences on social media, which means that social media did in months what the medical establishment had failed to do in decades. But the word hysteria casts a long shadow. The assumption that women exaggerate, that their pain is emotional, that their symptoms are not quite real, that assumption is still in the room at every medical appointment. It is in the 30-minute wait. It is in the prescription for anxiety medication instead of a pain management referral. It is in the decade it takes to diagnose endometriosis. 2,000 years is a long time for a wrong idea to live in a system. And wrong ideas do not disappear just because the language around them changes. The wandering uterus is gone. The 30-minute wait is still there. If this resonated with you, or if you recognized your own experience somewhere in this history, I would love to hear about it in the comments. These stories deserve to be told, and the more we talk about them, the harder they are to ignore. If this felt important, please give it a like, hit subscribe, and ring the bell so you are there for the next one. Because what we are uncovering on this channel is just getting started. We will see you in the next one.